All right, recording is in progress for those that are not able to join. My name is Todd Warren. I'm here with Dr. Mark Murphy, Clinical Director of Persomnus Sleep Technologies. Is that the full name?
Sure, absolutely. Sure.
Persomnus. Everybody knows Persomnus. Great product. But Mark's going to be sharing some amazing information, and I think Mark and I
you're going to be sharing some pretty amazing information too.
That too as well. But I'm really excited about yours because the information that you're going to be sharing tonight is probably one of the largest hurdles for dental sleep medicine focused dentists that is currently out there. Obviously, you got the big ones, billing and those type of things, but what you're going to be talking about tonight, I'm very excited about, and I think everybody else who's on the call should be excited as well. It's going to be a lot of golden nuggets. We're going to have some time at the end for Q&A as well, but I think last call we had, Mark, in part one of this three-part series that we're doing, you and I kind of arrived in agreement that the focus here is to gain momentum in dental sleep medicine and keep it. And that's one of the hardest things to do, is to gain the momentum and keep it. And that's why we titled this "Taking Your DSM Practice to the Next Level in 2022 for real this time." So it's a hard thing to do, but we're going to show people how to do it.
I like that you said that, and you made up the title, and I absolutely love the title, "For Real This Time," because it's really easy to sit back as a dental sleep medicine provider and say, hey, I found this magic bullet, and it lasts about 3 months or 6 months, and you get some customers in, you get some clients in, some patients, and things are going great. And then what do you do next? And so the reality is, how do you gain the momentum and keep the momentum? And it's going to require a variety of different strategies and tactics at different times in an evolutionary process for your dental sleep medicine practice. And that's really where working with dental sleep profits like we have, and doing other things like we've done, all kind of fit into an overall strategic plan for customer acquisition, for patient acquisition. And that's, you and I use that business language all the time, that sales language all the time, and we're not used to using that as dentists, but that's really what it has to be. Where do we get our customers from? Where do we get our patients from? And if we don't have a plan for that, then you just sit back and hope. And hope is not a good strategy.
Definitely not. You might as well go to Vegas.
Yeah, absolutely.
Yeah. So why don't you take it away, Mark? We'll get into our part two of our three-part series on taking your DSM practice to the next level.
Will do. And as I predicted, the room's starting to fill up, just like I said, as soon as we started talking. So thanks, everybody. You've got my email on the bottom. Feel free to reach out to me if you've got any questions, other than what happens at the end of this thing. Last time I talked, I opened up and I said we were going to do, we had two objectives. I was going to give you some tools, and I was going to give you some solutions. And we're going to continue to do that through the course of the next this webinar and one more. We're going to continue to talk about what tools do you have available to you to use, and how do you apply those as solutions, not just grabbing tools off the shelf and using them willy-nilly, but how do you take that tool and specifically use it? My wife and I were actually putting up this rod and attaching it on the two ends, and we used a piece of wire today, and I needed a pair of pliers to tighten the wire, and I needed a pair of wire snips or wire cutters to cut the end of the wire. And they're different tools. And so you can't just grab the wrong tool and twist the wire with the cutters. You'll accidentally cut it when you don't want to. You can't cut the wire with the pliers, because it's just going to grab it, and there's no cutting edge on it. So it's not just about having tools. It's not just about using tools. It's about taking those tools and applying them to the right time, to the right situation, and the right application. I think we all understand that. The second thing I talked about last time was this overview that we painted a picture of. There's 4 different boxes, and inside each box, there's many different decisions to make. Different decisions we can make about how are we going to test our patients? Do we want to dispense the test? Do we want to refer to an outside third party? Do we want to refer to local physicians? No wrong answer, but we have to have a strategy, and then we have to support that strategy with the right kind of systems in place. How are we going to treat? What kind of devices are we going to use? Are we going to go precision, or are we going to go cheap? Are we looking for efficacy, or are we just trying to beat our way to the bottom line? And then finally, what are we going to do from a billing and documentation standpoint? Are we going to try and figure out sleep billing? Are we going to try and figure out how to use, Dentrix or EagleSoft and figure out a way that we're going to use that for our documentation and SOAP notes? No, that's not going to happen very well. So most of the time, we're just going to hire a third party, and we're going to figure that out. But there are choices that we can make inside these different boxes. Tonight, we're going to talk about the first box. We're going to talk about screening and marketing. We're going to talk about how do we acquire patients. You can think of that first box as the patient acquisition box, which the two things we would generally do is we would screen our own patients, and then we would find a marketing strategy to get more patients after we've run out of our own patients. Because once we've screened our couple of thousand patients you have in an average dental practice, then you're relying on some small percentage, 25 maybe, of the new patients who come in that might have sleep apnea. So it's going to look like this, and it's going to be an evolutionary process for most practices. Now, some practices have already been screening and they're past that first stage of evolution. But for most of us, we should talk about step one. How do we screen our existing patients in our own practice for obstructive sleep apnea so that we get an opportunity to treat them? And then we'll talk about what can we do from an internal and an external marketing standpoint. And then where else can we get patients, just like your specialists, whether it's an endodontist or an oral surgeon or periodontist, how do they work their magic as a specialist to get referrals from other general dentists who don't do that particular specialty? And if we stop and think about dental sleep medicine that way, you're probably likely to have some friends and neighbors who you like and they trust you, who could refer you patients. So we're going to talk primarily tonight. I'm going to talk about screening our existing patients, and Todd's going to talk primarily tonight about external marketing, because those are the two levers that are the easiest to pull on. And I'm going to talk briefly in the beginning about internal marketing, physician referral, and other dentist referral, because those are things that are going to come for us. Internal marketing, right out of the box. Physician and other dentist referral, they're going to evolve over time. That's where I got that term, that this is an evolutionary process. See, you're not going to walk into a physician's office and say, hey, send me some patients. And they're going to go, great, I'll be happy to. You've got to earn that trust by seeing some of their patients serendipitously, by treating some patients and referring them some patients, and by asking for referrals. And that process is going to take time, and it's going to take persistence. And so while you're developing the physician and earning the trust of them and developing the relationships and the trust of other dentists in your area, how can we screen and do some internal marketing? So let's talk about that first. So internal marketing, whether you put Facebook posts up about your own practice, there's a lot of pundits, Todd can talk at length about this, but, some mix of, personal information about yourself and your team, what kind of things you're doing outside and inside the practice, what kind of charities you're supporting, a little bit about your practice, a little bit about dentistry, some mix of Facebook posts that just keeps you connected to your customers, to your patient base. Your website has to speak volumes about dental sleep medicine. I think most dental marketing people, I will defer to Todd's expertise on this, but he's guided me in this direction, so I'm pretty sure he'll go this way. We've got our own specific website that speaks to dental sleep medicine that's a little bit separate from a dental website and a dental orientation. And then anything you might want to do inside the practice, having posters or tabletop placements or trifold brochures. You can post your credentials. You can have press releases that are published. Maybe you're lucky enough. I've got a friend of mine across town, Anju Ely, who's on the news about once a quarter on Channel 4, our local news station. And man, she just knows somebody there. She treated somebody there. And so they love her to death. And she's great. She gets on TV and she gets to post that message about dental sleep medicine, oral appliances. And guess what happens when she does that? Boom, her number of leads goes up dramatically. And then you could have a video loop in the reception room. You could mail out stuff if you're still mailing out, statements. You could put a stuffer there. So there's a number of different ways that you could market internally to your own patient population. But listen to me, that's passive marketing. And we're gonna defer the term passive marketing, because later on we're going to talk about how we might switch that and make it a much more active conversation, make it a much more intentional conversation. But should you be doing all these things? Absolutely. Should you have posters up in the waiting room? Absolutely. Should you have brochures? Absolutely. Why? Because for some patients, just seeing that sparks a little bit of interest, initiates a conversation. But again, it's passive. It's not you initiating the conversation, like when you do a Epworth Sleepiness Scale as part of your screening process or do a stop bang analysis. We'll talk about those in a minute. These are opportunities where patients see something and say, hey, doc, I think that might be me. Or, hey, doc, I have a CPAP, and I don't like that. So these are passive things that you lay out there that you hope a patient notices. And I think of these, and Todd, you know the term for marketing, bluebird. These are bluebird opportunities, where somebody just kind of walks in and says, hey, you treated a friend of mine, or hey, I saw this thing online that you do this. That sounds like me. Can you help? Awesome. Do these. have those in place. Is this going to be your main source of anything? Oh, hell no. No chance. But you should do this because these are little mental reminders for people to see this kind of stuff all the time. Now, when we talk in a few minutes about screening patients, as I'm screening patients, I should be doing a couple of things. I should be screening them with the objective of treating them in a system that I've chosen from those different boxes we talked about. But at the same time, I should be thinking about my future. I should be thinking about how am I going to get patients when I run out of my own existing patient population to screen. And so I should be sending some of my patients to my local physicians. Yeah, I should begin to establish some rapport, some acumen, some street cred, if you will, at being effective using oral appliances to local physicians. How do I do that? Well, when you knock on their door and you ask them for referrals, they're going to put up all kinds of barriers. They are accustomed to being asked that by all kinds of people. Everybody wants their business. I don't think that's the right way to walk in. I walk in with this document. This is the ProSomnus case registry. You take a look at your last 20, 30, 40, 50 cases, whatever you've been doing. You document all the changes in AHI and mild to moderate, severe. And I bring this in along with a copy of the AADSM and AASM joint guidelines. And I staple one business card on top of those two documents. We show up at the front counter. We ask somebody if we can get their attention, if we could just get a handful of business cards because we have a need to refer patients to them because we're screening patients for obstructive sleep apnea and we need a place for them to get tested. So when I knock on a pulmonologist's or a neurologist's or ENT's door that's boarded in sleep medicine, and I tell them I want to send them patients and I drop off one of my business cards and a little bit of proof of concept of what I've been doing, they usually invite me in, get me coffee, and want to talk. And that's a different way of knocking on that door than asking for patients. Instead, tell them you're going to send them some patients. You'll get their attention. You'll get a whole box full of cards from them. And then by God, send them some patients. Now, don't send all of your patients to a third party, sleeptest.com or the equivalent. Send them some patients. Which ones? Well, maybe you like the efficiency of dispensing your own. Maybe you like the efficiency in that box of using a third party. But send some of them to your local physicians. Who do I send? I send all of my Medicare patients that I can because they need a face-to-face visit anyhow. So it isn't like in Michigan, I can just order the sleep test. I need a physician's telemed or live visit for that. I send them anybody who I suspect will be severe because there's a chance that patient's going to end up being directed towards CPAP anyhow. And I send them anybody who has a very challenging medical history, a complex sleep history. So anybody who I think in my triage that I'm responsible for, that if I'm going to say this patient needs an HST, a home sleep apnea test, I have to be certain that there isn't a whole lot more going on. Because if there is, they might need a polysomnogram. They might need a physician consultation. So if I'm going to elect to order an HST in Michigan, which I can do legally, I can't interpret it, can't read it, understand that, but I can order the test. I have to be sure that that's the only question we need to answer. Does this patient have sleep apnea or not? That there isn't a lot more going on. So if there's a lot more going on, complex medical history, with their Medicare, I think they're going to be severe, send them to the local sleep physician. That's probably, 40% of my patients. Also, if they've already got a history with a local sleep physician, honor that. So now we're maybe up to 45, maybe almost 50% of my patients will send them to a local sleep physician. So now I fulfill that promise I had when I dropped this form off. I'm sending the patients. And guess what? When they see the results you get with their patients, even if they've said to their patient, well, go ahead and try this oral appliance, but they don't work. And they tell them that sometimes. They start to come around. Do they come around after one patient? No. After 2 or 3? Yes. 5? Yes. It takes time. It takes persistence. It takes quality. It also takes, now hear this, and don't hear this as a big plug for ProSomnus. It takes us making the choices to use better devices. If I send them back with a crappy device that gunks up, that's uncomfortable to wear, that has a lot of side effects, and they're complaining and bitching to the physician, they are not going to send me a lot of patients. But if I send them back with a device that patient's telling me it's really comfortable to wear. They're sleeping so much better. Their subjective signs are great. They do a follow-up sleep test. The results are good. The HI score's down. And the device looks good and clean. And they see them. They do see them, by the way, at least annually for follow-up. And they see that device and they see that treatment being successful, the patient being compliant. You win their hearts. So that's how you win physicians, slowly, persistently over time, and by demonstrating very accurate results. Now, with my local dentists who don't want to do sleep, I play this little game that I learned from orthodontists when I was in dental school. They said, we're going to teach you how to do ortho. And all they did was scare the hell out of us. They scared us to think, oh my God, there's no way I want to do ortho. That stuff's so complex. Fast forward 30 years and this Invisalign stuff comes out and everybody can do ortho. Well, I like to train my local sleep dentist. I tell them that I'll come in and do a lunch and learn to show you how you should screen. And if you want to learn how to treat, I'll tell you. And I talk to them about side effects and I talk to them about what we do. And, you know, I probably tell them 3/4 of the story, maybe 80% of the story. I don't tell them everything, but I tell them enough that if they're interested, they should go out there and learn how to do that, and they can. But also where there's a little healthy dose of concern or skepticism on their part as to whether or not they're going to be comfortable doing that. And sometimes they say to me, listen, maybe I'll just send them to you. And I said, that's great. So we've got 3 or 4 physicians that refer to us, 4 or 5 dentists that refer to us, but they have to know how to screen and they have to know how to have the conversation. So we still have to train them and train their hygienist and train their team on Epworth Sleepiness Scale, on screening. I'm going to have to re-screen that patient in a consultation visit because here's the beauty. That dentist just has to say, yeah, it looks like you might have perio. And they send you to the periodontist who confirms that diagnosis. Looks like you might have sleep apnea. And they send you to the sleep specialist who happens to be a dentist. See, I can be a sleep specialist without being a physician. I can be a sleep consultant without being a physician. And I can confirm that they're at high risk and I can get them tested. So having these different opportunities that you're thinking about how you're going to develop them over time will help you evolve from a core where you have your patients to treat. And then as Todd's going to talk to you about, and then how do you reach outside your existing patient population, maybe through some Facebook networking, some Facebook ads, things like that in your own environment to increase the number of leads, increase the number of patients, which by the way, some of them need a dental home as well. That's kind of cool. That's one of the hidden things Todd doesn't always talk about. He talks about getting you sleep patients, which he's done an incredible job. I don't want to brag, but 70 or 80 leads in that first trial we did with you was just crazy. The number of leads we got. I'm not a dentist for doing dentistry. I'm a dentist for doing dental sleep medicine. So those patients aren't going to find a dental home, but some of those patients also needed a dental home. And so it's kind of cool. You get them as a sleep patient. You might also pick them up as a dental patient as well. So think about, how do I find physicians? How do I find local dentists? What kind of passive information do I have outside my practice to help get these people a little bit excited? So those are the 3 things I want you to have in the back of your mind as we move to talk about screening your own patients. So everybody knows what that lesion is and what it looks like. And when I'm in a large room full of people, it's hard to do here in a webinar like this, but I'm in a large room full of people, 100 people, I say, everybody who screens their patients for oral cancer, raise your hand, and everybody's hands go. Everybody's hands go. I go, keep your hands up, keep your hands up. If you screen your patients every single time they get their teeth clean, leave your hands up, and everybody's hand stays up. I say, now leave your hand up if you found an oral cancer in the last 12 months. And almost every hand goes down. And I say, do you realize that if I said to you, how many of you screen every patient for obstructive sleep apnea? Hardly any hands would go up. It looked like it did when I said, how many of you found a cancer? And then, but if I said, if you did screen, how many of you would find sleep apnea in 25% of your patients, every hand in the room would stay up. You see, we're already taught to screen for perio, bite discrepancies, third molar presence, absence, ectopic eruption, endodontic therapy, but we don't usually put an emphasis on sleep-related breathing disorders. Now listen to the difference in this statement. Screening, treating. Nobody said we have to treat those things. When I was a practicing dentist, I didn't do perio, I didn't do third molars, I didn't do root canals, I didn't do ortho. I had a family practice with an emphasis on occlusion and TMD, occlusive rehabilitation and TMD. I got to choose what areas I wanted to work in, what I wanted to become kind of a specialist at. So just like this, I could choose to not treat sleep-related breathing disorders, but I have a responsibility not just a kind of an ethical responsibility, but I have a moral responsibility that's been written in 2017, not yesterday, not a year ago, but in 2017, the ADA passed a resolution stating that we should be screening for sleep-related breathing disorders. So the story I like to tell, and the story that attorneys like to tell, is that not now, but maybe in another 3 or 5 years, there's going to be a patient in a general practice who passes away from a comorbidity related to obstructive sleep apnea, who sues their dentist for non-diagnosis, just like they've been sued for non-diagnosis of periodontitis or occlusal disorders for years. And that's likely to be successful, especially when you've got publications like this, white papers, resolutions that state we're supposed to be doing that. Can you imagine a conversation? Well, were you screening these patients? No. Well, is the patient over 50? Are they male? Are they obese? Do they have a large neck? Do they have hypertension? You know all those things from their health history. That's 5 out of the 8 stop bang, which we'll talk about in a second. 5 out of the 8 risk factors. That patient's at high risk. I'm not trying to put a guilt trip on you. I'm not trying to scare you. I'm telling you what attorneys have told me. Our attorneys, the Ken Burleys, the Jamie Machinskys of the world, who defend dentistry, sleep dentists in particular, say that day's coming. That day is coming. Well, by educating our patients, not just passively, but actively, we can have the opportunity. We can screen a patient, tell them they're at risk for perio. They can choose not to get treated, but as long as we have documentation in the chart, we're kind of clean. Same thing is true with sleep-related breathing disorders. I'm not saying you have to do a sleep test on everybody, refer them to another dentist, or get them treated. I'm saying that we, like those other disorders that we're responsible for screening, we just have to screen them. And our responsibility is to educate those patients. And patients are educating themselves a lot already. Their beds are telling them their respiratory rate, their heart rate, and how well they slept last night. They're wearing Fitbits. They're listening to Snore Labs. There's an incredible amount of wearable technology out there that's very accurate. It's giving oxygenation data, heart rate variability. So patients are coming in highly educated already without maybe making a connection between sleep apnea and the data that their wearables are giving them. It's our responsibility to complete that story, that loop, to tell the rest of the world space out there what's going on. And to have those intentional conversations, I like to bring a parallel up that happened to me one time when I was talking about shade for a Vita porcelain company. How do we have these intentional conversations rather than just these passive conversations? Well, I was lecturing about shade, and I was talking about this little machine we use, and this one dentist in the room says, "Yeah, I love that little machine. It works great for me." I go, "Why don't you tell everybody how to use it?" And he says a couple of things, and he says, "And when I'm taking shade on all my new patients, I do this." And I said, "Wait a minute, what did you say?" He says, "When I'm taking shade on all my new patients," and I go, "Wait a minute, you take shade on your new patients, not just a patient where you're doing a crown or something, or veneer or something?" He goes, "Oh yeah, I take shade on all my new patients." I go, "Why do you take shade on all your new patients?" This is brilliant. The guy says, I used to ask my patients if you could snap your fingers or you could wave a magic wand and you could change just one thing about your teeth, your smile, what would it be? And I always felt like I was telling them that their teeth were ugly. I always felt like I was saying, your teeth are ugly, and if you could wave a magic wand, what would you change about them to make them prettier? And he goes, I always felt like that was a little invasive of a conversation. But I learned that if I just started taking shade and announcing it to my assistant and they were writing it down, when I got through taking shade on the anterior teeth, I'd be doing an exam, perio, occlusion, TMD, and I'd say, now I want to take a baseline shade of your teeth, and we'll put the little shade taking machine on there, and you're writing stuff down and calling it out. When we got done, there's only 2 kinds of patients in the world. I said, what are they? And he said, patients that ask you what shade they were, and patients that don't. And the patients that ask you what shade they are, you tell them, and you say, well, you're a 2M2 or A3 or whatever it might be. And then they said, what's that? And you said, oh, here, let me show you. And you show the shade guide like this, arranged from lightest to darkest value. And you can see where 2M2 is right about in the middle, just slightly left of center. And they go, ooh, that's kind of dark. And you go, no, that's actually a very average and common. Nobody wants to be average and common. That's a very average and common shade. We see that a lot. They go, I want to be lighter like over here. What did that patient just do? The patient just opened the door, not you. the patient opened the door on an aesthetics conversation, a cosmetic conversation, the possibility of doing something about their smile. Maybe for the first time, you gave them the possibility with this intentional conversation that was not judgmental at all. Well, that's what I would argue that the Epworth Sleepiness Scale does. The Epworth Sleepiness Scale does not predict at all, does not tell us very well at all whether or not a patient has obstructive sleep apnea. It is required by a lot of insurance companies, so you're going to have to fill this information out if you're going to do dental sleep medicine. And a score of 9 or higher means they have excessive daytime sleepiness. What does that mean? Nothing in terms of obstructive. There's very poor correlation. But it's an opportunity for us to start a conversation intentionally with each and every patient who we think is at risk. See, being tired is one of the 8 things. And we need 3 of those 8 things to be at moderate risk. 4 or more puts you at high risk for obstructive sleep apnea. And those things are the stop bang analysis, which has a 92%, listen to that, 92% correlation. There are pundits out there who are recommending we stop doing sleep tests and start just using the stop bang because it's pretty predictive for whether or not a person has obstructive sleep apnea. So what a great conversation starter. I've noticed here, you're kind of tired. Or if they're an overweight, over 50 male, 3 risk factors. And if you count their neck, 4 risk factors. If they have hypertension, 5. And you know that from their chart in looking at them. Overweight, you know they're over 50, you know they're male, at risk. And even if their sleeping scale says not tired, then you just turn it around and say, I noticed here that you mentioned that you're not excessively tired during the day. However, and you start to talk about the stop bang. What an incredible way to bridge this Epworth Sleepiness Scale to the stop bang. What's the stop bang? The stop bang is God's gift to dental sleep medicine from an analysis standpoint with a very high correlation to whether or not the patient has sleep apnea. Do you snore? Are you tired? Has anyone ever seen you stop breathing or gasp for air while you're sleeping? Do you have hypertension? I probably had GERD or arrhythmia or some of the other comorbidities. I'd broaden that 4th category. I think the analysis that most people would do on this algorithm would produce that as well. When it was originally done in Chest Magazine, which is the American Thoracic Society's journal, it just looked at blood pressure. And then are they overweight? Is their BMI 30 or more? You don't have to put them on a scale. You don't have to measure them. Just look at a person. If they're stocky, their BMI is 30. It doesn't take much to get to 30. And if they're over 50, you know that from their chart. Neck circumference, guess at that. If they're overweight, they probably have a large neck. And then finally, and it'd be 17-inch for male and 15 female. And then if they're male, which you know in their chart. So wait a minute, the only thing you have to ask them is snoring, or has anyone ever observed you stop breathing? So now you've got this Epworth Sleepiness Scale, which opens the door to the conversation. 6 out of the 8 items, you've got the information on already to begin the stop bang analysis. You say, let me just ask you, do you snore? Or has anyone ever seen you snore? Oh yeah, I do snore. My wife complains about it all the time. Has she ever seen? Yeah, she says I gasp for air. Boom, you're just checking boxes and counting them up. And once you get to 3, they're at moderate risk. 4, which is about 80% correlation. 4 or more, 92% correlation. So even though this indicates, you know, if I had you in front of me, Todd, even though this indicates you're at high risk for obstructive sleep apnea, it's more than just snoring. And I talk about the comorbidities. I talk about the increased risk of heart attacks. We go back to this slide here, where I talk about these 8 different slides I use when I'm working with a patient. And this one right here talks about they're 23 times more likely to have a heart attack, 4 times more likely to have a stroke, 5 times more likely to die of COVID if they get it. I start to talk about painting that picture and I go, man, I didn't know that. Well, yeah, but I don't know for sure if you have obstructive sleep apnea. I'm only telling you that based on this data, this risk, you're about 90%, 92% sure that you have it. The only way we can tell for sure is get you a test. Let's go ahead and get that ordered up. This presumptive close, this presumptive idea that let's go ahead and draw some blood. Let's go ahead and take an x-ray. We don't know until we take an x-ray. We don't know until we draw your blood. We don't know till you step on the scale. We don't know till we take your hypertension, take your blood pressure. We have a presumption of risk. And so we're going to do a test. And that's how we're going to confirm our diagnosis. That is part of medicine. And nobody gives them a choice as to whether or not they want to do that. It's medically necessary. We don't use that term and we don't think that way in dentistry. So I like this idea of a presumptive close and this risk analysis and this moving them to a test. Love, for me, everybody can be different in their box for testing. I love to not do the test myself. I love to send them to my physician or send them to a third party for verification with a physician as to whether or not they have sleep apnea. I'm again, and yes, like the general dentist, referring them to a specialist to see if they have the problem.
Yeah, you might go into this in a little more detail. I just had a conversation at length today with a dentist about this presumptive close approach, where you're dealing in the medical community. If the doctor orders an X-ray, there's no question there. You're not saying, well, hold on a minute, how much is it? There's just this presumption that you're going to do what your doctor says. Why do you think that gap exists in dentistry? Would you mind elaborating on that a bit?
Yeah, thank you. That's something we're gonna cover off a little bit down the road in other webinars, but I'll answer that today. So the biggest reason that non-presumptive close exists for us in dentistry is because we don't have a third party taking the risk for catastrophic loss. That's the definition of insurance. In dentistry, insurance stops at $1,000 or $1,200. So the conversation is, I'm always trying to sell a patient a service or a treatment that there isn't the coverage for from a third party standpoint, and never feels like it's absolutely necessary because it's not life or death. We can fix the tooth or we could lose the tooth. And if you think about it, insurance is when a third party takes the risk for a catastrophic loss. Most medical insurance starts at $2,500 or $5,000. That's many times the deductible. I mean, that deductible is many times the total coverage for dental insurance. If your car insurance worked like dental insurance and you totaled your car and they gave you $1,200 or $1,500 and you had Geico, you choked that little gecko till his eyes popped out, right?
Yeah.
And you say, well, wait a minute, I'm going to go over see Progressive. I'm going to go see Flo and see what she's got. And she says, well, I've got insurance for you. I can save you $300. So, well, wait a minute, what does that cover? You say, well, it covers oil changes, lube jobs, and filters twice a year, new wiper blades every 3, new tires every 5. You say, that doesn't sound like insurance. It sounds like a maintenance plan. See, dental insurance isn't insurance. We call it that, but it's the wrong word. So we've had to justify, we've had to protect ourselves from getting paid. We've had to beg and plead with patients to do the things that we want to do for them to keep their teeth in the best comfort, health, aesthetics, and function as possible. In medicine, they go, we're going to draw some blood and get an X-ray today. Nobody talks about the co-payments, the deductibles. Nobody makes them sign a financial agreement. They just go get the test done. And then they go, well, we're going to need an MRI on your shoulder. Nobody says, and the MRI is going to be $1,700 and your deductible is $1,000 and your insurance is going to be an 80-20. Nobody talks about that. You just go get your MRI. Then they tell you need surgery. And now you decide to either live with the pain or get the surgery done. Well, you decide I'm going to get the surgery done because you know insurance covers the bigger stuff. That's what it's designed for. So we have this mismatch of language and this mismatch of how we've learned to behave. It's sad. It's super sad. Super sad. But we can.
I don't want you to give it all away because I want people to show up for part 3. But that's it is tough to take off the dental hat and put on the medical hat.
In the next part, we'll talk a great deal about this presumptive close. We'll talk about how do we set up systems that help the patient move forward rather than putting walls that they have to jump over. And we'll talk about a friend of mine who was seeing 60 patients a month, walking in with a script and a sleep test, and they were treating 14 of those patients every month. That's 22%. Because they were putting up all kinds of financial barriers to protect them from not getting paid. And ergo, those systems were flawless. They were fabulous systems, but that's good management. But leadership is making sure we do the right things, not that we do things right. And so they had the wrong system in place. It was a well-managed system, but it was the wrong system in place. Instead of helping, these were these insistent systems that prevented the patients from moving forward. We changed those systems literally overnight, and they went from 22 to 80% closure. Overnight. The next month, they closed 80%. And by the time they polished their verbal skills, they went to 90%. That was, think of this, they went from 14 to 54 cases a month. Think about that. That's 40 more cases. If that was $2,500 a case, that's $100,000 a month. That office increased their revenue by $1.2 million. And I literally spent a half day with their team. It was not, and they were like, well, wait a minute, what if we don't get paid? I go, well, what if you don't get paid? Would you rather do 14 of those 60 cases and be guaranteed of getting paid? Or would you rather do 54 and maybe one or two of them doesn't pay you? The math is compelling.
Yeah.
But we get all caught up in dentistry on these systems that we carry over from dentistry and try to use in medicine. And instead, what we should do is walk around the medical office for a couple of days and see how they do it. In a medical office, you go, I walk up to the front desk and I go, so what do I owe you today? I go, I will bill your insurance and we'll let you know. And 3 months later, you get a bill for $168 and you're like, what the hell is this? And you have to go back and look and see this EOB and, oh yeah, I had that x-ray, they did a blood test, and my copayment must be $168. But it's like from 3 months ago. It's a totally different world.
Yeah.
Totally different world.
Yeah. And you had mentioned, I think you mentioned to me about that, doctor, or it was you yourself. In the last 4 years, you've only had 2 people not pay you, right?
That is correct.
Yeah, that's amazing. So if you were thinking about joining us for part 3, and we'll let you know when that is,
Wow.
Don't just think about it, make a commitment to actually be there, because you know what Mark's going to be sharing, literally, he just said it, added an additional $100,000 in revenue per month to this practice with a half a day of training. And that's the information you guys are going to learn in part 3 of this webinar series. So be sure when I send out the invite, mark it on your calendar.
Truth be told, that was a very busy practice, already well established, incredible, flow of patients. Most practices are seeing 6 or 8 patients a month, and they're closing 1 or 2, and I get them to close 4 or 5. That's much more common, but still, those numbers are compelling.
I don't think anybody's going to argue with those numbers either.
They're still good.
Yeah.
So now I'm kind of done, and I'm going to hand off to Todd, because what I've told you is, here's how you screen. Here's how you say here's how you take a patient in your practice who's unaware, and you make them aware and interested, and you get them to commit to wanting to do something. And now you get them tested. Now there's a whole nother box we got to talk about testing. There's a whole other box we got to talk about in terms of treating. That's not why we're here tonight. But here's how you screen your own patients. And who do you screen? All of them. Where do you screen them? Easiest is probably hygiene. I would start with all of your existing patients, do maybe a 6-month cycle of all the men over 50, and then the next 6 months, all the rest of your patients. That way you don't overburden your hygiene team with these extra conversations. You break them up into a couple of groups. And now in 1 year, you've screened all 100% of your patients. You've also made this a part of your health history form, not just your update history form. So now every new patient coming in, there's a sleep-related breathing disorders conversation you can have with them. And now you go forward. And that gives you a year, maybe 18 months to start developing relationships with local physicians, find other ways to market externally, and start to have some of your friends and neighbors refer your patients. So Todd, I've been screening for a year. I've kind of gone through all my patients. I'm doing some internal marketing. I'm still knocking on physicians' doors, and I'm not getting anywhere too quickly. My local dentists are still a little afraid to send me patients. And I know you're an expert at this because we've talked and you've helped us with an incredible bump in leads. How do we market externally? What's cost effective? What makes sense? What's easy to do? How do we get the word out on our practice externally? That's the next.
It's a good question, and it's something a lot of sleep dentists struggle with. They have implemented sleep. They're screening their patients. They're doing exactly what you said. They're trying to communicate with local physicians, but they just can't seem to get that bump in momentum and keep that snowball growing. And that's where we have found just an incredibly effective tool to reach out to the public, because there's a lot of people in the public who are aware of obstructive sleep apnea. They've already been diagnosed, but they're not following the treatment protocols that they've been prescribed, or they're experiencing signs and symptoms of obstructive sleep apnea. They're terrified to go to their primary care because they don't want to get stuck into a CPAP, and they do nothing about it. So there's this huge education curve or I would say there's a huge lack of education where paid marketing can fill a gap and get those people reaching out to you. And Mark, you talked about that a little bit with internal marketing, where those conversations happen more naturally because the patients are starting the conversation now because of maybe a pamphlet they saw in your waiting room, or they saw John Doe's testimonial playing on that looping video thing in your waiting room, whatever it is, or they saw a Facebook post that a friend liked. All those things create the conversation. And that's what we do with Dental Sleep Profits, is we focus on educating the public. And what that does is it raises their level of awareness and causes them to reach out because they want the solution that you offer. So I'm going to share my screen here. And just to let you guys know, I am going to be going very, very fast through this presentation. I do not want you to try and retain 100% of the information that I'm going to be sharing. I want you guys to just hear one gold nugget, if that's all you take away, and run with it. And I'm going to be sharing the exact thing, the exact 5 steps that we at Dental Sleep Profits do to help practices generate $300,000 in additional sleep apnea treatment in a matter of 12 months. We've done this for a number of practices. It is possible. I know that number seems really big, but if you have a well-oiled machine, if you add the appropriate systems in addition to a well-oiled machine, you can very, very successfully add another 300,000 in sleep apnea treatment. So I'm going to go quick and I'm going to get right into step 1. Step 1 is getting the right message in front of the right people at the right time. So there are different components to that. There's the actual message you're sharing with people, how you target them, and the timing in which you show them that message, meaning when do you show them that education? We're going to focus on the messaging first. I want you to go after the low-hanging fruit. That's people who are CPAP intolerant. I just spoke about that. Or they're displaying the signs and symptoms of obstructive sleep apnea. So when you are advertising, you want to focus on people who are unhappy with their CPAP. Their primary care never told them that oral appliance therapy was an option. So just presenting an alternative to CPAP, you're already getting people's attention. Super, super simple. And then you start in your education, you can start going after people who have excessive daytime sleepiness or mouth breathing, or you can go through the Epworth Sleepiness Scale. You can go through the stop bang. Has anyone observed you snoring? Can they hear you snoring through walls? That's a really good sign. Or they observed you stop breathing. You know, you can go through those things in your education, and incredibly effective. It's incredibly effective at getting people's attention. And with that education, a lot of people, when they see an oral appliance, they're like, oh, that must be like Invisalign or something. Or I actually saw one of those on Amazon. I think I'll just order it off of Amazon. Very, very important in your education. Focus on how oral appliance therapy works. If they're buying that $99 oral appliance off of Amazon, they are not getting a quality appliance. Very, very important that you explain why they should be reaching out to you, which is where explaining how oral appliance therapy works or what to expect during the treatment process. So focus on education in your messaging. And also, this is a little bit of the sales side, which I want to focus on, is paint a picture. And, you know, ask yourself in your advertising the question, imagine yourself in this situation. Imagine sleeping with your spouse again. Imagine getting a restful night's sleep and you're not falling asleep at your granddaughter's birthday party anymore. You know, or what if? Ask the question, what if? Help people envision the future that they could have in your messaging. That's a big, big part of helping people reach out, because just like with real estate, buyers have a severe lack of imagination. That's why there's, you know, a multi-million-dollar industry called home staging, because home buyers have a lack of imagination. So do your patients. So help them see what kind of life they could live in your messaging. And then we have targeting, Facebook and Instagram. The reason we focus solely on Facebook and Instagram is because the user demographics match your patient profile. And let me explain what I mean by that. These are the numbers as of December 2021 on Facebook users. Notice that from 35 to 44, all the way up to 65 plus, is more than 50% of Facebook's users, which falls right in line with your patients who are now displaying signs and symptoms of obstructive sleep apnea. And my generation saw the introduction. I'm at the very early end of the millennials. I was born in '83. We saw the introduction of the internet. We grew up with Facebook, and we've seen multiple social media platforms introduced. we are a little bit more comfortable switching social media platforms. So we see a lot of the demographic in my age group, that 35 to 44, who are also on Instagram. So you notice almost 50% of the 35 plus is Instagram's user base. And you're like, Todd, I've never even been on Instagram. Statistically, your patients are on Instagram. So we want to focus on those. Also, data. Facebook owns Instagram. Facebook collects an incredible amount of data on its users. If you pick your nose with your right pinky finger, Facebook knows it. They know it. They know who your relatives are. They know where you shop. They know what bills you pay, and when you pay them, they know everything about you if you use their platform. You can use that to your advantage, and that's the reason we want to focus on Facebook and Instagram when we're targeting patients. And the second thing is understanding your community. How far are people willing to travel to your practice? Because part of advertising on Facebook and Instagram, you get to decide geographically. You can fence where you want to target people. You can target people based on where they live or whether they have traveled to your community and then left your community. You can, whether they have visited, the options are incredible. So understand, in Manhattan, people are only willing to travel about 20 to 30 minutes. And that might be a half a block in Manhattan. They just don't want to travel more than that. But if you go to rural Kentucky and you have a sleep practice there, people are used to driving very long distances. So you can extend your advertising radius to 60 miles because people will drive 2 hours to the grocery store in rural Kentucky. So understand your community. And then also, do you need to provide exclusions? And this is something a lot of dentists don't like to talk about, and I don't actually like it either. We did this with your campaign, Mark, where there are certain zip codes where it's just a reality that most of the people in that zip code are not going to be able to move forward with treatment, whether it's because of the insurance coverage that they have or because of their socioeconomic status. That's just a reality that we deal with in business. And if you are spending money to target people who are eligible for oral appliance therapy, you want to know areas that you might need to exclude in your advertising. And also get creative with your testing. Because Facebook and Instagram collect so much data on their users, you can actually target people based on who their employer is. The US Postal Service is a great company to target. UPS, USPS, and FedEx are great companies. If you have federal workers, if you have military bases near you, if you have, we had a client in Pennsylvania, Pfizer, Pepsi, Frito-Lay, all of these big pharmaceutical research companies are in the area that offer their employees great benefits. We targeted them. You can target people based on what pages they like on Facebook. You can target income ranges. You can target interests. The list goes on and on and on. So, get creative, test different targeting strategies. You can go into Facebook's ad manager and you can literally type in a word. You can type in employer, Dan's clothing, and oh wow, that's an actual targeting option that I can use. So experiment with that. And now we get to the part of step one, which is timing. You want to target people who have CPAP and other signs and symptoms of OSA, as well as people who manage other comorbidities while they are talking about it. And you guys have probably experienced this. It's probably, if you're on this call and you're a client of Dental Sleep Profits, it's probably why you're a client of Dental Sleep Profits, is because I targeted you based on where you went to school and the topics that you're talking about with your patients. And you can do this, you can target people based on interests, and Facebook will target you based on what you're talking about. I did this with my mom. She told me that my grandmother needed an apple tree that was leaning against her fence. She wanted me to take my chainsaw, go out to my grandma's house and cut it down. Well, I told my mom, I was like, it's the holidays. Every chainsaw maintenance shop is closed. I don't have a chain sharpener. So I'll have to get the chain sharpened on my chainsaw before I can head out there. We're in Oregon. Everybody has a chainsaw. So less than 24 hours later, I'm scrolling through Facebook just randomly at leisure. I'm scrolling. what on earth? There's an advertisement for a bar that you slide over your chainsaw and it sharpens it by simply running the chain. Never did any Google searches, never typed anything into my phone or on my desktop computer, because Facebook will also target you based on what your spouse searches on your IP address as well. I started seeing ads for drapes. I was like, why am I seeing ads for drapes? My wife is on the same IP address. So I'm seeing ads for drapes now. Lucky me. So this is why Facebook advertising is so effective. You can target people while they're talking about signs and symptoms of obstructive sleep apnea. You can target people while they're leaving a pulmonology office. Within 2 hours, they can see your advertisement. And when the pulmonologist says, we're going to prescribe you CPAP, they say, well, this doctor's saying otherwise, that I have options. We've had patients call our clients and say, I just left the pulmonologist 2 hours ago. I saw your guys' ad. I'm bringing myself and my husband into your office to talk. Great. So timing is so effective with Facebook and Instagram advertising. Step number 2 is capturing the right info using a sleep funnel. And honestly, what I mean by that is you drive your advertising clicks to a page where you collect their information, where they can request a consultation. And to do that, number 1, you want to have a clear call to action. You want to limit their browsing capabilities, and then you want to collect the right info. And having a clear call to action, it is the absolute cornerstone of making sure that your advertising dollars are getting you the best results possible. So very important with your clear call to action is that your call to action needs to match whatever next step that you are telling the patient to take. If you're doing video advertising, if you say call the office, but your advertisement has a button that says click learn more, your call to action is not consistent. Mark, you did this with the videos that we did for your ads. You say click the learn more button right below this video. You want to have a consistent call to action. And then your call to action needs to be above the fold. What I mean by that, this is going back to the 1940s, 50s, 60s, 70s, and 80s, when there was nothing, where predominant majority of the advertising was print advertising. You wanted whatever action, your call to action, to be above. You didn't want to have someone unfold something to figure out what you wanted them to do. If your call to action is call the office, you want that to be one of the first things they see before they start scrolling on their phone. That's what it means when we say your call to action should be above the fold. So if your call to action is for someone to fill out a form and click a submit button, they should be able to see that opt-in form before scrolling once. Very, very important. And then your call to action actually continues throughout the funnel. And this is just marketing 101. Your only goal with marketing is to get someone to take the next step. You're not trying to close the deal on the very first interaction with that person, similar to case presentation. When you're speaking to a patient, you're just trying to get them to accept a home sleep test. You're not trying to close the deal at that meeting. You're just saying, here's our next step. And that rings true through a marketing funnel. After they submit their request for a consultation with you, your next step is to get their sleep study faxed over or emailed over to your office. Okay, that's great. Maybe your next step is to get a copy of their driver's license and insurance card. Whatever that next step in your workflow is, you need to define that throughout your funnel. And then this is the tough one for a lot of people to swallow, is limiting browsing capabilities. You need to limit the number of decisions that visitors to your funnel can make to one of 2 choices. And the only option they should have when they arrive on that landing page is to either call your office or submit their contact info to request a consultation. If you give them the opportunity, I've had clients ask, like, Todd, can you put a link to our website? Can you, in addition to the opt-in form, can you put a button so they can call our office? And my answer is always no. And the reason is, and I'm going to cite a couple studies that are outside dentistry, but the reason that these studies are so effective is because these companies deal with millions and millions of visitors to their website per day. This is some split testing on big companies that have taken the navigation bar. So like the About Us, services, all those little buttons at the top and bottom of your website, they removed all of them. And they saw a 30 30 to 40% increase in conversions as a result of providing the people no navigation options on those pages. And this is the difference between those two pages. The one on the left is AmeriFirst's standard landing page. You notice all of the browsing options. There's home, the learning center, buying a home, home improvement loans, all these options, social media links, buttons all over the place, lots of stuff to click. Their second page that got 30 to 40% more conversions, there are no navigation options. It's just download this Power Savers Grant Buyer's Guide, enter your name and answer this question and click the download the guide button. And this is HubSpot. HubSpot is a CRM program or software that people use, and they saw the same exact thing. You see, this is conversions with navigation, and the percentage increased is in that fourth column there, the percent lift. In their demo and free trials, they saw 16 to 28% increase in conversions as a result of providing no navigation option. Navigation links distract visitors from the conversion goal. And I don't know if anybody has kids, they'll notice this is from the movie Up, and you're probably saying squirrel in your mind right now. You're distracting people by providing navigation options, links to your website, lots of stuff they can click. You want to keep them focused. Next is collecting the right info. You need to ask, what info does my staff need to help them prioritize and follow up with the right patients and filter out the patients that are not qualified? It sounds wrong to say that there are patients who are not qualified, but again, there are some who just can't move forward with treatment because of insurance or because of finances. So far, we've covered step 1 and 2, getting the message in front of the right people, the right time, and then capturing the right info using a sleep funnel. Those 2 steps cover the first 3 stages of what we call in my marketing. We developed this is the 5 levels of sleep awareness. It's actually developed from the 5 levels of buyer's awareness, and we changed it to sleep. And with this educational advertising approach, you've taken someone who's potentially unaware or they're problem aware, and you've now made them solution aware. You know, they know their desired result, but they're not aware that your treatment can provide that result. Our goal is to get them to stage 5 of awareness, and we're going to get to that. But let's look at step number 3, which we call opportunity management, which is strategic soft follow-up. And what soft follow-up? It's a combination of things. It's a combination of automation and the soft follow-up itself. This can be a huge expense. Lead follow-up requires payroll. It requires time from your staff. If it starts consuming too much of their time, it's a big hit to your bottom line. So you have to have a system that you can use to automate communications that move your patient leads towards their next step, so that your staff doesn't have to do 100% of that legwork. So let's look at soft follow-up real quick. The key to this is to automate where it makes sense. You don't want to automate everything, but your staff is wearing a ton of hats already, and you want to alleviate adding more and more to their plate, because they're going to go full mutiny on you if you add too much. These communications that are automated, don't make them too clinical. And I want to look at a couple examples. This is, let's say we're automating text message. This is a textbook do. This is a good thumbs up communication. Hi, Thomas. Just got your request for a sleep evaluation with Dr. Timmons. Might not be available just now, but give our office a call ASAP, because I know the doctor will want to get you on his schedule soon. I'll call as soon as I can if I don't hear from you. Chat soon, Krista. Now let's look at a big no-no. Look how clinical this is. This is Krista from North Atlantic Sleep Center in Amherst, New Hampshire. I'm texting you to follow up on your interest in the oral appliance for better sleep management, yada, yada, yada. I'm not going to read that if I'm getting this. It doesn't sound like a human, and I'm just not going to read it. So don't be too clinical. And I wanted to touch on some automation tactics that are absolutely awesome. And it's kind of what's working well for our clients right now. And some of you might have heard of the law of reciprocity. And what the law of reciprocity states is that when people receive something, they feel compelled to return the favor in kind. So Mark, if I go and you're traveling for Prosomnus, you're at a trade show, and you come back and your wife goes, I don't know why, Mark, but Todd mowed our lawn. You're like, well, dang it, now I got to go mow Todd's lawn. You feel compelled to return the favor.
Absolutely.
And we can actually use this you can use this to your advantage. And you can actually automate what's called a voicemail drop. What a voicemail drop does is you record
You
a
had us
message.
do this. You had us do this for our customers.
Yeah, yeah. And so Mark records a message. He says, "Hey, this is Mark. Sorry I missed you." Or Dr. Mark Murphy, sorry I missed you. But I saw that you requested a consultation with me. I want to get you on my schedule. Very, very important. This is a very serious condition that you're dealing with. And I don't want this to go untreated. And I want to make sure you have all the options available to you for treatment. So give Kim a call if I'm not available, and we'll get you on my schedule. Click. Our system, or whatever system you're using, can deliver that recorded message directly to someone's voicemail inbox and show that they have a missed call. And your patient thinks, "Oh my gosh, the doctor just called me." That's amazing. Like, doctors never call. Usually they just have staff call. So they feel compelled to return the favor in kind. And we tested this. This is a part of our dashboard where you can see, I don't know if you guys can see my cursor, but this is where our system left that voicemail recording. And what I want you to notice is this. That voicemail was left at 10:15 a.m. Look when the patient called back, 10:15 a.m. Immediately, it's like, "Oh crap, I missed the doctor's call. I have to call them back." Filter and prioritize. The reason we do this is because your staff is wearing too many hats. And this message is from Chuck Norris. When you're wearing too many hats, they are bound to tip over. That is wisdom incarnate right there. And I actually heard a really funny joke that I think will lighten the mood while I'm going through this so fast. Chuck Norris does not sleep. He waits. So we'll lighten the mood. But filter and prioritizing is essential. You can notice, like, this is an example of our dashboard that our clients use. You might have something similar that you are able to organize your patients with in your dental, your practice management software, but you can see some of these categories that help filter and prioritize: state insurance, new leads, responsive hot leads. These are people who have responded to text messages or emails, or they've called back. And then these are some of the filtering things we do. State insurance only. State insurance leads, they'll get a text message automated from our system that says, "Hey, thanks for reaching out. We want to be upfront, let you know your insurance doesn't cover this, but if you'd like to discuss finances and how to get this treatment, you can call our office." And then prioritizing leads, when a lead reaches out and they have an active sleep study, our system will tag them. So if your staff only has 15 minutes to call people to get them scheduled for their consultations, we want them focusing on the people who have sleep studies in hand. That's the soft follow-up. The hard follow-up is exactly what it sounds like. And there is some automation involved, but it is harder than the soft follow-up. So what I want you to think about, and the hard follow-up is essentially dialing numbers, getting on the phone with people. But I want you to think about when people are on their phones and most likely to see your ads. They're either in bed because they're awake, or they're sitting on the toilet while they're on a break at work, or they're any number of places. They're not in a place or a time when they can immediately call your office. Late evening, after business hours, like I said, sitting on the toilet, they can't always call your office immediately. So you have to do the hard work and follow up with them. And 90% of the time, they probably will not call your office unless you have some sort of system in place where you can encourage them to do so, like the voicemail drop automation. But here's something that you can use even if you don't have a system like ours, because I wanted to give you guys something you could take away from this that you and your staff could do immediately. And this is called a pre-call text message. And it literally, don't even change the wording. This is as simple as it gets. "Hi, Thomas. I'm finishing up a quick task here at the office, but I'll be able to call in about 5 minutes." You don't say, "Hi, this is Krista from, Functional Sleep. Dr. Mark Murphy told me to call you." No, it's like, "I'm finishing up a quick task. I'm going to call in 5 minutes." If you send that text message, they're expecting to receive a call from a phone number they don't recognize. They are literally 100% more likely to answer your phone call if they're expecting it. And that's what this pre-call text message is able to do. And this is just the state of communications. The reality is that a majority of your patients prefer text messaging. It doesn't matter what their age. A majority of your patients prefer text message communications. So if you're not doing it, you should be doing it. Step number 5, creating a video testimonial strategy. And we're almost done here, guys. I appreciate your patience. Again, I know I'm going quick, but I want to get as much in as possible. The reason you want to focus on creating a video testimonial strategy is because stories matter. And what you want to do, you want to plant the seed, you want to ask the right questions. And I'm not going to get into the recording the video aspect, but just know cell phone videos work the best. So we're not going to get into that for time's sake, but I want to share why stories matter. I know this big old buff jack dude, he's a good friend of mine. This is Wayne Wyatt. Wayne Wyatt, Mark, you're muted right now.
Who put a different head picture on my body? What the heck? I mean, the guy going like
Photoshop is getting incredible. So this is Wayne Wyatt, good buddy of mine. He played D1 football for the University of Arizona. He's an orthodontist in Oklahoma now, but he let his fitness slip, and he decided, you know what, I'm going to do P90X. And he did it, and he got amazing results. He was actually in the workout videos for P90X2, which is a sports-based fitness program. And he just got incredible results. Well, I found this guy on YouTube, and I was like, oh, this guy's awesome. He's got a family. He goes to church. He's exactly like me. He has a super busy job. At the time, I was an engineer. I was like, I have failed P90X 7 times, like maybe the 8th time with this guy's help. And this guy, like, if he can do it, so can I. This is me, 60 pounds heavier. And when I found Wayne, I related to him. His story resonated with me. I decided I can do this. And after 6 months, I was able to get results similar to Wayne. And this is why I'm not like, I hate sharing this, but it's the best example I could think of why stories matter. Because I was able to do exactly what Wayne was able to do because I heard his story. And your patients, remember I said, home buyers have no imagination. That's the reason home staging exists as a business. Your patients have no imagination of what their life could be like unless you're able to help paint that picture for them. And this is why a patient testimonial strategy is so important, is because your patients are able to put themselves in the position of people they don't know and relate to them and say, well, they're just like me. My life could be like that too. So here's how you plant the seed. And this could be done from the minute they step in your office. Paint a picture of expectation for them. Let them know when I deliver this appliance, here's what you need to look for. You're going to notice that you feel more well-rested. You're going to notice that you and your spouse have better intimacy because you're sleeping in the same bedroom. You're going to notice that you're not falling asleep at these times during the day. Help them know what to look for after you've delivered the appliance. And then when they come back, they're going to be, oh my gosh, you were exactly right. I experienced this, and this. So paint that picture for them. And then before even delivering the appliance, ask for the testimonial. Set that expectation of that they are going to share their story. So when they agree to move forward with treatment, you say, hey, would you be up for, us recording you and, what your results were like if this works really well for you, which I'm sure it will. And like, oh, of course, I'll share my story when I come back in for that 3-week, 4-week checkup appointment, but set that expectation. The questions to ask, they should paint a picture for them. And keep in mind, you want the viewer to be able to put themselves in the position of your patient. So your questions need to be able to do that. Your questions need to paint a picture for the viewer that helps them relate to your patient's situation before oral appliance therapy. I haven't slept with my wife in 7 years. I snored like a locomotive. I was falling asleep at every single family gathering. I had erectile dysfunction, and now that's working again. There's just so many things. And then you want your questions to have that viewer envying your patient's story after they've experienced the results of oral appliance therapy. So I want to touch on a few of those questions. What was your experience with CPAP? Great way to help viewers relate to your patients, because oftentimes they have similar stories. How is your sleep apnea affecting your life? What made you reach out to us? How was your first experience with us? What's life been like with your sleep appliance? What would you tell someone who hates their CPAP or is maybe CPAP intolerant or thinks they might have sleep apnea? And there you go. You have painted a picture for your viewer. You have staged your home, and now you have buyers for your home. You've alleviated the problem of a lack of imagination. And now, only thing left to do is recap what we've covered so that you can be reminded of what step you're going to take away from this. Step 3, we got the soft follow-up, a lot of automation to alleviate the burden off your staff. The hard follow-up, doing the work. Hopefully you can take that text message, pre-call text message, and start doing that immediately. That will have, even with your dental patients, that'll get you so many more responses. And implementing a video testimonial strategy. And that's what will get you all the way to our stage 5 of our levels of sleep apnea awareness, where they know the treatment you provide, but they just need the details to move forward. And then, that leads into the presumptive close as well. So hopefully this has helped you guys. What Mark shared, what I shared, hopefully it's helped you recognize how having systems in place to make sure that these things are operating at their highest efficiency can help you generate and keep momentum going in your practice. And my question that I'll kind of leave everyone is, what does your system look like now? And if your response is, I don't really have systems, I would encourage you, reach out to Mark, reach out to myself and ask, what should I do? If it's testing, Mark has an incredible wealth of knowledge about testing. If it's on the clinical side about oral appliances and what works best for certain clinical situations, Mark has a ton of knowledge. If it's about acquiring patients who you don't have to convince to move forward treatment, it's just a matter of working out the details, then I can be a great resource for that. But if you don't have those systems in place, you have to take action, because you owe it to your patients, you owe it to your community, knowing what you know about obstructive sleep apnea, the fact that you can help them, you owe it to them to do something about it, to have those systems in place to get more of them treated, more people healthy, save more lives. So, Mark, that's all I got. We don't want to leave it to a gamble. We want systems. So.
Well, it's been fun. It's always fun tag teaming with you on stuff like this. I can see some comments coming in. Everything sounds good. You certainly got us a lot of leads by doing those very 5 steps. You had me record that phone call kind of message, the ninja tactics, all that kind of stuff. We did fight you a little bit in terms of doing some geographical limitations and stuff like that. You told us that would limit some of our leads, and it did, but everything else worked out for us. We had just a ginormous bump in leads. There's no question about that. It was amazing. So thank you for that.
Awesome. Oh, cool. We got a nice comment from Dr. Mel Pearson out in Statland, Iowa. He says, I can't believe how happy I am. My fan, Todd, you're awesome. Appreciate that, Mel. I'm glad you were able to make it on the call.
Your checks in the mail. Your checks in the mail.
Yeah, your checks in the mail. Yeah. But yeah, if you guys have any questions, pop it in the chat box. If you guys want to ask Mark anything, ask me. Put it in the chat box now. We'll give you guys some time to type out those questions. Otherwise, we'll get ready to wrap things up here. Mark, do you have anything else you would like to add?
No, I think we covered it all. I guess what I'd want to say is there's always this large gap between knowing and doing. And you actually exampled it when you did that P90X thing that you were able to accomplish. I've run several marathons. I have 2 artificial knees. I'm a cyclist now, do century rides and stuff like that. But the difference between knowing we want to do a certain series of things to improve our golf game, or to improve our health and our fitness, or to add dental sleep medicine to our practice, knowing that, and the difference between doing that is the gap that we're trying to cross here when we have these kinds of conversations. We want to find whatever magic story inspires you, or maybe whatever accountability partner you need. And sometimes, unfortunately for us as dentists, when you hire a consultant, or you hire a marketing company, or you hire somebody to come in and teach you how to do something, suddenly when you have to pay for advice, you start taking it. So I think closing this gap between knowing and doing are the things that are in motion here. And the beautiful thing is this is really easy to do. It just takes the doing. It really just takes the doing.
Yeah. I just spoke with a dentist today, and she responded. She's like, Todd, that's a big investment for your services. And I go, that's actually a good thing. And the reason it's a good thing is we've had some very successful sleep practices who've invested in our services. And because our fees were just a drop in the bucket to them, they didn't take it serious. When it actually hurts a little bit, when you actually have to wake up 6 days a week and do the workouts, and then you have to do the nutrition. You have to, like we were talking about before we started recording, you have to get in the golf simulator, analyze the swing, figure out what mistakes you're making. That's a good thing. When you start doing, that's a good thing. So, it's just a matter of, are you experiencing enough pain right now to actually be committed to the doing? There has to be a little bit of pain. And that's not always financial. That might be you have to have some tough conversations with some key staff members. That might be it. There's a number of things, but change is good. Change is good.
Yeah, for sure.
All right. Looks like we got one question. Once we were to begin using your service, what time frame before ROI? Be conservative. I would say on average in the first 30 days, and again, this varies greatly because not every office has systems like Mark has, or has systems or the staffing in place to be incredibly effective. But the average that we see right now is within the first 30 days of someone using our program, like Dental Sleep Profits, is closing 3 to 5 cases in their first 30 days. Now, I'll be honest, Mark didn't close 5 cases in his first 30 days. That doesn't happen for every practice. But what we generally, and this is conservative, what we do see over the course of time, that snowball increases. And this is the weird thing is once our clients start getting into month 6, 7, 8, 9 with our program, that's when they start seeing people who saw their ads 5 months ago finally call the office and say, hey, I saw your ad, but I wanted to try my CPAP again, and it's still not, I still can't wear it, so I'm calling you now. So, but hopefully that answers your question, George. About 3 to 5 cases in the first 30 days is the average, conservatively. So, yeah. Do we have any more Q&A? That was in the chat. It says, do you guys agree with the statement that trying to work with PCPs would be more productive than pulmonologists, cardiologists, or the specialists, et cetera? What do you think, Mark? PCPs or specialists?
I work with specialists. I do have one PCP really that sends me some patients. I guess I've gotten a couple of sporadically from others. It's a different business model to work with the PCPs. They can't read and interpret the sleep tests. And so getting them to send you patients still leaves you in need of the connection of a sleep specialist, a pulmonologist or a neurologist are the most likely. Actually, the cardiologists, the PCPs, cardiologists, PCPs, urologists, endocrinologists are great sources of a different business model, but it's a different kind of sales cycle. It requires some different logistics, and you still have to get that patient tested. When you're working with a pulmonologist or a neurologist or an ENT who's boarded in sleep, the test kind of comes with that patient, and I kind of like that business model. But the other one works. It's just different because you still have to have a test loop, and if that test loop doesn't include the local physicians, that kind of pisses off the local physicians if you're working with the PCP or the cardiologist and eliminating them. But that can work. It's just it's a very different business model.
Yeah. And Mark, even when you're communicating with specialists, are you including their primary care, like saying,
Always.
hey, our
Always.
mutual patient reach out? Okay. Good.
Always. Yeah. We send it to the oddly enough, the primary care and the specialists do not want to know what's going on till you're done. But my general dentists want to know every step, just about every time I see a patient. So it's funny, they want to kind of micromanage or at least be aware of what we're doing. But every time we send a communication to a physician, they have to enter it in their software, in their EMR, and they have to record it. They have to have read it, and they have to scan it in. Somebody has to do that. So they don't want any more communication till we're done with our patient, then send one final report over that they scan and upload once.
Okay.
But you should work that out with your physician. You might find a physician that wants detailed accounting every step of the way.
Yeah. Okay. Yeah. I've heard, I've heard, I've heard the opposite from some of our clients where they've been very successful with primary cares.
I didn't say
that's great.
It doesn't work. I said it's a different business model.
Yeah, exactly. Yeah.
It's a very different business model. There's even like the IAOS, has a very aggressive business model where they put an employee inside the primary care's office, and that can be very, very functional, very functional. But again,
if you can make that happen, it's
a different business model.
Yeah. Okay, great. Well, it doesn't look like we have any more questions. Oh my goodness. Do I call or check your website to schedule a time to talk? George, yeah, just visit dentalsleepprofits.com and you can schedule a time to talk. So we're approaching, gosh, almost an hour and a half. So I apologize about how long that went, everyone, but I think there was a lot of good information that was shared tonight. Hopefully you can take away. Mark, we'll send out a blast for the recording. Thank you again for your time. And guys, stay tuned. Watch for my email on part 3, because that one's going to be a big one. There's going to be a lot of good and actionable info that's shared.
How to close these cases, how to close.
That's the big one, how to close. All right, Mark, thank you so much. We'll see you. I imagine we're going to have our meeting before AADSM. So we'll see you soon.
Roger that. Thanks, man.
All right. Bye, everyone.